Welcome to today's CAP Echo. We'll be talking about SSRIs today. Glad you could join us here at the noon hour in the midst of your very, very busy days. And so if we can go ahead and type into the chat, and we can go ahead and move on to the next slide here. Go ahead and put in your name, what organization you work for, the county where you see your patients, so we can see where everybody is coming from. And also, what is your kind of go-to stress buster that you like to recommend for your patients? So for those of you who don't know me, I'm Joanne Jung. I'm a general pediatrician here at UCSF. I mostly see patients in San Francisco County, and I like to recommend exercise. And that's what I go to myself. And there's been some evidence showing that it compares fairly well to some of the antidepressants that we use in terms of antidepressant effect. So go ahead and type in a little brief introduction into the chat as people are starting to filter into our virtual room. And let's go ahead and move on to the next slide. And if somebody wouldn't mind kind of typing into the chat, like what our prompt is for folks who are just starting to come in. All right, so a couple of announcements, again, as people are filtering in. We are coming in from everywhere, all over the state, and many of us are eating lunch, and that's okay because this is the lunch hour. Please keep your cameras on if you can, because it's great for us to see each other, especially as we're discussing the case a little bit later on today. It's just easier to have a conversation in this virtual space. Also, we will be recording, but we're only recording the didactic presentation. We're not going to be recording the case presentation, but this didactic presentation then will get, the recording will get put onto the CAP website usually within about a week or so. Another announcement that's new, something that's coming soon, is something we're calling the CAP Core Badge. We want to recognize those of you who have been putting in the time and the commitment to show up here month after month. And so for those of you with perfect attendance here at the CAP Project Echo for these first 6 months, you're going to be getting a badge. And this badge syncs up with LinkedIn so that you can put this on your LinkedIn profile. We recommend that you put this badge on your CVs or resumes, just saying the CAP Core badge, really recognizing core capacities in pediatric mental health, diagnosis, and treatment for these core areas, which correspond to the 6 sessions in our Echo. So if you show up to all 6, if you've been showing up so far and you show up all the way through December, you'll be getting this badge. You don't have to do anything extra to apply or anything else. So a way of recognizing your hard work and your time and your commitment to this learning. So, and finally, we do need a case presenter for this coming month in November, and we'll be talking about autism. And so if you've got a patient who might have autism or with autism, and there's something about either the diagnosis or the management that you'd love to talk over in this supportive group, please let me know, and I can give you the details on how you can prepare to share this case. This is all teach, all learn. We are learning from our real life cases, patients that are keeping us up at night and making us scratch our heads and going, now what? Now what do I do? They don't have to be super complicated. Simple questions are welcome. We are all learning. And so please let me know if you've got a case to share. And as another little carrot, you don't have to pass that MOC Part 2 quiz to get MOC Part 2 credit if you share a case with us. So please let me know if you've got a case to share. And again, for those of you who are coming in, if you didn't get to see, just type into the chat a quick introduction, who you are, what county, and your favorite stress buster that you'd like to recommend. All right, now with that, I'd like to introduce our speaker for today. We're lucky to have with us Dr. Ryan Rampersaud, who is a child and adolescent psychiatrist here at UCSF in the Division of Child and Adolescent Psychiatry. Dr. Rampersaud completed his MD and PhD in microbiology and immunology at Columbia University and his psychiatry residency and child and adolescent fellowship at UCSF. His research program focuses on the role of the gut microbiome and the development of psychiatric disorders, including mood disorders, and understanding the biological mechanisms by which early life adversity affects physical and mental health. Dr. Rampersaud will be speaking with us about SSRIs today. And with that, I'll pass the virtual mic over to him.
Thank you so much. I'm excited to talk to everybody about SSRIs. No disclosures to disclose today, so we can go to the next slide. Okay, so today, main goals are for us to describe 3 commonly used SSRIs, including usual initial and target dosing, talk a little bit about SSRI risks, including common side effects, including risk of activation, and then really also develop our ability to talk and about SSRIs and benefits, risks, and potential side effects with the families that we're speaking to or seeing in our practices. Next slide. So this is just a model. I like to start out, because I'm a scientist, about thinking about how SSRIs work. And so for a very, very long time, we always thought that maybe it was that there was sort of low serotonin, and that was sort of the driver for psychiatric conditions. And SSRIs were sort of meant to kind of fill that tank back up. You can hit next. And so the idea is that you block presynaptic serotonin reuptake, and in doing so, you can treat depressive and anxiety symptoms. I put this in here just to say that I think it's slightly more complicated, but regardless of the mechanism of action, which is something that we think a lot about, these are quite effective and useful in practice for treating some of our patients that we see. Next slide. So general guidelines when we're thinking about SSRIs, a question that often comes up is, well, is there one that's better than another? Is there one that I should be using above all others? And the reality is that their efficacy is kind of similar. And when we're thinking about how to select an SSRI, there are a couple of kind of guiding principles here that I will often use. So one includes past response history. Maybe I've had a patient who has been on something before, and they say, you know what, this really worked for me the first time I came off of it, and now it's not working so well, and now I'm not feeling so well. And so you might consider restarting that. Side effect profile, so some might be a little bit more sedating than others, some may be more activating than others, and we'll kind of get to that a little bit later. And that can be one consideration for choosing an SSRI. And then coexisting medical conditions. There are some SSRIs that maybe are a little bit better or suited to patients who maybe have medical problems or are taking lots of medications. And again, we're going to kind of come back to that in a minute later on in the presentation. So general guidelines again about how long does it take to work? This is the question that everybody asks. When am I going to feel better? And so we often sort of say, listen, it's 3 to 6 weeks between reaching a therapeutic dose and improvement in symptoms. And sometimes you can see remission, that is sort of really significant reduction to sort of pre-morbid levels of depressive symptoms by week 4. How long do I kind of continue with this? Well, if you don't see any improvement after 8 weeks at an adequate dose, and we can talk a little bit more about what that word means, we can either switch to another antidepressant or augment with another agent. And we can talk a little bit about switching versus augmenting later on. And interestingly, SSRIs have shown greater benefit in anxiety disorders than depression, especially in younger children. So if you've got some kids who are treating or being sort of plagued by really significant anxiety issues, SSRIs might be particularly useful. That doesn't mean that they're not useful for depression, but we're noticing that there's something different there in which younger kids tend to respond a little bit better to SSRIs, again, for anxiety disorders than depression. So we're going to hit on all of these. This is sort of a little bit of a guidepost for us as we kind of go through all of this. So we can hit the next slide. So when we think about treating our patients, it's sometimes helpful to kind of divide things into phases of treatment. And we can think about the acute phase, continuation phase, and a maintenance phase. And I think sometimes this has been helpful in for patients to hear, um, to kind of help give them a little bit of expectation of what it's going to look like for their lives, in terms of being treated with an SSRI. And so when we think about the acute phase, that's that phase that's at the very beginning where we started something, we're trying to reach that adequate dose where we've gotten full a response and then ultimately full symptomatic remission. And remember, I said 3 to 6 weeks, you're kind of maybe starting to think about seeing a response, and maybe by 4 weeks, but really by 8 weeks, we're hoping to see full symptomatic remission before you start to make decisions about changing or switching or augmenting. And so once we get through that acute phase, we've reached a good dose where our patients, I apologize, I keep saying participants, our patients have been have reached that dose where they're feeling kind of back to normal almost. And then we're sort of in this continuation phase. We continue the treatment. We want to sort of put in place other interventions like maybe therapy, maybe other behavioral interventions to avoid relapse. And that can last for a period of time, 6 months to a year. And then maintenance, we're kind of avoiding recurrences and potentially new episodes. And so just this is a little bit of sort of definitions on the side. Response really means no symptoms or significant reduction in symptoms for at least 2 weeks. When we talk about remission, we're saying that there's a period of 2 weeks, less than 2 months, with none or very few symptoms. And then recovery is really an absence of significant symptoms for about 2 months. And then I think relapse and recurrence are sort of kind of self-explanatory. Next slide. So when to prescribe in primary care, we put this slide in here. I think one of the things that comes up is, listen, we can identify patients that really would benefit from an SSRI because their depression is moderate to severe, because they're significantly impaired, they can't take care of their bodies, they can't take care of their cells, they can't do their sort of normal responsibilities. But there are other sort of factors that also kind of come into play here. And that's it's this sort of dance that we have to sort of be in, where we're thinking about the whole person and thinking about, is this a patient that I really think is going to do well with an SSRI? And so in primary care, I think a couple of guiding principles. One, uncomplicated, mild anxiety that maybe progresses, or depression that progresses to moderate to severe depression. Again, if the person is having really significant impairment, I can't go to school, I can't get up to eat, I'm not showering, I'm not taking care of myself. That's another point where you might say that this is going to tip me into this place of saying, I really think I'm going to strongly recommend an SSRI for you. Maybe you started out and family wasn't so keen on a medication and you said, okay, let's give it a little bit of time. Let's do a therapy. Let's have some kind of additional behavioral support. But really importantly, we're not going to just implement this and then sort of disappear. We're really going to give it a significant amount of time and say, let's give it 6-8 weeks. Let's see how that goes. Let's see if we move the needle at all. And if you had no response to an intervention, or really only a slight response, we haven't moved the needle enough, my kid is still not going to school, my kid still isn't eating, then we really want to think about kind of advocating for a medication as a support there. Patient and parent agreeing after being educated on medication risks and benefits is really critical. We want parents to be involved and active participants, and we also need our kids to assent to the medication. Here's the other piece that's more of a logistical piece. Maybe this is a patient that you don't know so well. Maybe this is a patient who doesn't quite come to appointments. And that, while we may want to give them an SSRI, I think it's a real significant factor where we really have to think, how well am I going to be able to give really good care to this patient and monitor the progress on this medication? And then, what's your ability to consult and collaborate? Do you have some support? Surprise, we're here, so there's always some support. But are there other people sort of around? Maybe you have access to a co-located mental health person who can sort of also offer a little bit of support around some of this stuff. So these are kind of a little bit of some of the factors that kind of go in, and I think it's patient factors, but it's also on the provider side, right, we also have to really be in a place where we can do this in a great way. Next slide. So I won't go through this, but we have a lot of great evidence that says that this works. Okay, and I'm not going to go through this the studies because really the answer is this works. So let's do it when it's appropriate and when we can in a great safe way. So this is a slide, and you'll have access to the slides. I'm not going to go through the whole thing with you, but I wanted to sort of sort of hit a little bit of the differences between SSRIs and give a little bit of guidance maybe on certain indications where you might choose one over another. And so we talked a little bit about, the efficacy tends to be the same, but we might choose a different SSRI based on side effect profile, medical comorbidity, and some other issues. And so Prozac is probably the one that people know the most, and it is the one that has an FDA indication for depression. It has a very long half-life, but maybe more activating. And so you may think about fluoxetine for patients who maybe don't take their medication every day, who have trouble, like, even with the pill box, they still can't, like, Tuesday's gone, but they didn't do Wednesday or Thursday. And there it becomes not such a big issue if you skip a dose because the half-life is long. They're not going to have any withdrawal symptoms. They're not going to feel kind of uncomfortable. Sertraline may be a little bit more sedating. I tend to think about sertraline a little bit more when I have a kid that's maybe on the more anxious side, maybe more anxious kind of depression. And so I think sertraline can be really, really great. Luvox is maybe more used in the UK than it is here. We don't really prescribe Luvox, but it's there for your information. And then we have Lexapro and Celexa, which are maybe on the more neutral side. And here you get less sexual side effects. But if you have a kid who, and I use this often with kids who, maybe had seizure disorders or had other really significant medical comorbidities that were taking lots of medications, I tended towards Lexapro and Celexa because I knew there was going to be less interaction with their other medications. And then Paxil tends to be more sedating, but keep a note that it has the highest risk of weight gain. And so, at least in my practice, and I think most practices, it's sort of fallen out of favor. And it does tend to have a little bit more interaction with medications, but it's still in your arsenal if you should need it. Next slide. And so before starting medication, we always want to educate our families, tell them about the risks, benefits, and the side effects. We want to get consent from the guardian because we have to have partnership with our parents for this to work well. And we need the patient to sort of be at least somewhat on board and say, okay, I'm seeing that I need something else to be helpful. Because again, we want to partner with our kids. We have to have a safety plan in place, right? We really want to make sure that if something does come up, and we're going to talk about the black box warning in a second, if something does come up, we do have a plan in place for how families are going to respond and how the kid's going to respond. And just to note, there's going to be an SSRI about suicidality coming up later on. And so that will come up, and so you get a little bit more of that in a different echo. And then a schedule of visits. I really think that we want to think about the frequency with which we see people. And so at the beginning, when we're first starting, we maybe want to check in a little bit more frequently. And then as time goes on, we can space out the frequency of those visits. Next slide. So I alluded to this, which is, this is about consent and assent. And so really, I think this is probably not a surprise. We really need parents to be able to, and legally parents need to be able to say, yes, I agree, you should treat my child. But we also really want kids, depending, if they're at the right age, maybe sort of 13 and above, to really say, okay, I'm understanding and I agree to take this medication. Again, we really want to partner. Next slide. So in terms of side effects, when we're talking to parents about side effects, I usually just tell it to them straight. I don't mince words, but I do remind people that I tend to start low and go slow, and that usually mitigates some of the side effect risk. And so the big ones are GI distress, headache, we want to have them be thinking about appetite change, sedation, sleep disturbances. And then maybe for the older kids, you really do want to talk about sexual side effects because it is an important thing to kind of consider. And then on the right is just a sort of list of ways to maybe manage it. I think the guiding, and you can look at this on your own time, but I think one of the biggest guiding principles that I've had is people are always worried about side effects, but really what I would say is, listen, if they're mild and they're not totally impairing, a majority of these things will disappear within 1 to 2 weeks of starting the medication. And I think, you know, the placebo effect is real and setting expectation is big. And I think that that is a huge help to the patients that I see, at least. Next slide. So monitoring visits, we talked about this. Let's have a plan in place when we're seeing people. First month, monitor weekly. That's not realistic when you have 15-minute visits and your practice is totally packed, but maybe it's a quick email from mom. Maybe it's a check-in. And that can sort of go to 2 weeks if there are no side effects. In that second month, maybe you want to check in every other week. If you can see them, that's great. And then in that month, we're starting to maybe see therapeutic effects. And again, we want to partner with our families, their eyes and ears. They're going to help us make decisions about things because I'm not with you 100% of the time. And then in that third month, we're thinking about monthly during that first year of treatment if possible. But, depending on the patient, right, and this is where your clinical judgment comes in, that can be spaced out or condensed. And it's going to change over the course of treatment because things are going to happen and you may have to see somebody a little bit more frequently during particular times. Next slide. One of the big things that comes up is, does my child have serotonin syndrome? So this is one of the sort of more major side effects that can come up with an SSRI. It's not particularly common, but if it happens, you will sort of notice it and see it. And so these are just a bit of the kind of features that might help you distinguish, is this serotonin syndrome? And so it tends to happen within 24 hours of medication. You get this hyperreactivity, so this tremor and this clonus and hyperactive reflexes. And it can be treated and resolves within 24 hours. So it's something to watch out for, and we talk to our families about it, but I always remind people that it's really less of an issue, especially if it's an uncomplicated case without lots of other serotonergic medications, but it's something to watch out for, especially as we're starting the medication. Next slide. We started to talk about the black box warning, and this is super, super important. So in 2004, the FDA issued a black box warning, which said that antidepressants are associated with an increased risk of suicidal thoughts and behaviors in young people up to the age of 25. The highest risk is in that first 9 days of treatment, and it usually is with higher than usual starting doses. So again, I'm starting at a lower dose. And so I'm going slow and I'm really trying to mitigate some of this, but it's really important for our parents to be aware of this and to be monitoring for any behavior change around suicidality and to get yourself to emergency treatment if necessary, if this does present itself. Next slide. I'm going to skip this, but you can read this on your own. The point is that it takes a lot. It's a low risk kind of situation. It's not the most common thing that's presenting itself in terms of suicidality, but it is serious, so we have to pay attention. You can go to the next slide. This is just a list of, showing the potential. And so, go back one more. Go back one, sorry. And so just some predictors: female sex, previous suicidality, previous self-harm. So if you have a kid who maybe was already suicidal or was already self-harming, it might be something that you just want to pay attention to. And you can take a look at this on your own. Next slide. And then you can go 2 more, actually. So we always want to think about SSRI-induced activation, right? Because that's something that could come up as a side effect in the beginning. And you can sort of think of it, I call it like ants in the pants is when I describe it to like families, but it's just that irritability, akathisia, I can't sort of sit still. Sometimes people are worried about manic symptoms, but it really is this sort of, I'm just having a hard time sitting still and I feel uncomfortable kind of in my body. Next slide. And we can reduce the dose or hold the titration if you're starting to see that. And so the thing that comes up is like, oh my God, is my kid manic now? And so hit next. We want to distinguish behavioral activation from bipolar switching. One of the big pieces is the temporal nature of it. Behavioral activation occurs early on, initial days to weeks after the dose, whereas bipolar switching occurs later. Behavioral activation, it's not really a mood change. They're still depressed. They just can't sit still. They feel this sort of uncomfortable restlessness. Whereas bipolar switching is really associated with that mood change. And so be on the lookout for this because it can look similar, but these are some of the features that might help you distinguish. Next slide. And so then talking with parents, everyone's concerned. There's still stigma despite the world that we live in now. And then we also have to be like cognizant and sensitive to people's cultural beliefs, right? Because it varies from place to place. People are often worried about are going to become a zombie, zonked out, change their personality. Say, listen, there's going to be some ups and downs, but I don't think that it necessarily makes somebody different than who they are. Wouldn't my kid be better off not taking meds? And that is that graph that I showed you. You need to treat a lot of people to get the harm of suicidality. So it's not a super common emergent thing, but because it's serious, we always have to be paying attention to it. And so you can take a look at this, but really the main point here is depression is always worth treating. And really having untreated depression is a greater risk for harm to self than the smaller risk associated with starting the SSRI. Next slide. So I think we're getting close to the time being done, I think. And so I just want to say one thing, which is cross tapering. So maybe you're at the point where you're thinking, I have to switch, but I've gotten somebody up to a high dose. This is an art and not a science. So I would recommend call us. We love talking about cross tapering and we'll give you a whole schedule. But the basic tenet behind it is you start the new SSRI at a lower dose and you reduce the original SSRI and you sort of make these slow gradual changes until the old SSRI is phased out and you're only using the new one. And if you go to the next slide, this will be somewhat helpful. This is on the right-hand side are the sort of dose equivalents of SSRIs. And so you can kind of see 20 of Prozac is about 10 of escitalopram or about 50 of sertraline. And that can kind of help you decide where you're going to start. There is an art and there are other factors that are sort of involved. And so give us a call because I will often, when people call, I give a very detailed week 1, do this, week 2, do this. If this is causing a problem, hold and then start, so we can help you walk through in a more detailed way. And once you've learned it, then you're an expert and then you can do it on your own all the time. So next slide. And then people often ask about this SSRI discontinuation. And here are some soon. If you abruptly start, you get some of these sort of uncomfortable symptoms. It's not life-threatening, it's uncomfortable. So you get flu-like symptoms, insomnia, nausea, imbalance, sensory disturbances. I tell people about this only to say, you should talk to me if you really are unhappy about being on a medication and you want to stop. I'm never going to force you to do anything, but I need you to partner with me so that we can think of how to do this in an appropriate way. And here's the reason why. This is a thing that happens. The next slide. That's it. Yeah, we can skip this one. And so how long does treatment last? I always say at least 6 to 12 months. After a year, we can revisit it. And what becomes, it becomes a discussion about how well you've done, what are the other factors? Are there other stressful life events that are coming up? And then what do you and your family prefer? So for example, I had a kid who was great after 12 months, but she was going away to college and it was going to be stressful. And I said, I know you feel great, but I think you need a little bit of extra support until you get settled. And she agreed and she sort of stayed on it. And so that's just one kind of example of where even after the 1 year, remission was achieved, but I still thought, let's reevaluate after 6 months of starting college before you make that decision. And she was on board. And we're happy to talk about, if you just want to call and talk about how to do this or is this the right choice, we love that conversation. So give us a call. Next slide. I think that's the last one. And that's the references. So that's the end.
Thank you so much, Ryan, for that great talk. We don't really have time for questions. I didn't see any come through to the chat, but as a reminder, if questions did come up and you have like about 5-10 minutes to stay after the hour is over, we have like an informal chat time where we can talk through any questions that may have come up.
The PHQA is very good because then I can, focus on they feel bad and improve the dynamic between the parent and the child. Someone breaks down and cries, and at least you open the communication. But sometimes the one, like the daughter, will not want the mom to know that she's suicidal, and I don't know. They somaticize a lot. They'll come in with the calf pain or the urinary problems, and they've seen urologists and they've seen all these different places, but it's really whatever that dynamic is driving everything. And it's like all I can do is like refer. But in one case, she was on SSRI, and since she did declare feeling suicidal and stuff, the most I could do is, because I don't feel comfortable with this SSRIs and stuff, so I just bumped it to the next level and again referred, make sure they're connected to behavioral health. I'll see them, I think, if they return. I'll see them this week.
Good luck.
But
yeah, it's so common. I don't remember seeing as many before of like these teens or preteens like having panic attacks and not being able to get out of their car to go to school. I had like a handful, of them. Another one, like I got onto, I think it was Lexapro eventually that, it was Lexapro. It was the first try. And she's in school and doing great. She managed to get there. But her mom gave her like some of her out of it. Her value, I felt like to get her out of the car, basically. That's what it took. That like on Lexapro, she's been able to go, and like a couple of others where they were able to get onto their SSRI, stay on it, like the panic attack stopped, and they were able to go. But it just seemed like so much more common, where it's like panic attacks trying to go to school.
I feel like it has to do, a lot of it's like social media, but also like during COVID times, like during critical parts of development, right? We were kind of like, lockdowns or other things. And so I feel like, that's also affecting both pieces there.
Yeah.
Yeah, I think that's been a huge issue. And we know that, we know that exposures make anxiety better and avoidance makes anxiety worse. And with the pandemic, it was kind of mandated avoidance for all kids, right? That they were all kind of avoiding crowds and other people and schools for over a year, over 2 years for many of them. And so that all kind of builds up anxiety. And then kind of without, in the ordinary course of things, we have a lot of built-in exposures that, just going to school, you're getting out of the house every day, you're around groups of people and having all that practice, kind of tolerating all those things. So it's been a huge issue.
And even with like social media and the high accessibility, I feel like, again, during critical times of development, there's, significant like comparisons or, you know what I mean? Like so-and-so is like this, why am I not like that? And then that leads to more anxiety and and then also like social pressures, even the academic pressures, you get into like, the 5.0 students are looking down on the 4.0 students. Are you not taking 3 AP classes? Just so many factors.
It's so hard. And we know with social media that it's always kind of a skewed view of other people's lives. Like if I think about my Facebook, it looks, people post when they're on vacation and doing fun, cool things. They're not posting about, their everyday work and stuff. So it's never kind of an accurate picture.
Yeah, I think this is where, to me, this is where we have to partner with parents, because we have to do something at home to shift the environmental factors that are contributing to what's happening. Not to say that this person doesn't, maybe an SSRI is indicated, there's some biological basis, but in reality, especially with an anxiety diagnosis, I think to me, this is where like I have to partner with the parent and ask them to really, they have to do heavy lifting. It just is what it is, to change the environment and remove the gaming system.
I also have a question, because actually recently I had like for renewal of the DEA, I had to take like, extra those hours or whatever for the DEA. And they were doing a lot of like, especially like the adult addiction world. They were like, it kind of works for everything, but like the whole mindfulness approach, like, like really like I'm smelling a rose, and they were showing how like it activates different areas of the brain and how this can curb not just addiction to actual opioids, which is a big problem, but even carb addiction and other kinds of things in pediatric world. Because I mean, literally when I was doing my DA training, it was all like adult, and I was like really searching for some, and there was some interesting pediatric one, mostly about like the current fentanyl, kind of crisis, so to speak. But yeah, what are we doing? Like, I mean, I thought it was so great and interesting, and I wish like I can get trained in mindfulness, or you know what I mean? Like, I feel like that could do a lot for a pediatric population for treatment, but also prevention for when they become adulthood. It's just good skills, right? So I don't know what your thoughts are.
Be
They
curious.
have, oh, sorry.
Go ahead. Go
They-
ahead.
I mean, they have the AAP lectures because I've listened to them. They go over how to do the mindfulness. They go over, like you said, the senses, the 5 senses, and grounding and the breathing. And I try to throw that in too. And there are AAP didactics on it, just free online.
Okay, thank you. I'll have to check that out.
Yeah, no, I think definitely mindfulness can be a really, really important skill. And it like, especially with the anxiety disorders, this like the skill to be able to kind of sit with your experiences and without making judgment, is really, really hard when you're feeling anxious, and can also be because kind of what we're seeing like with the patient we heard about, that he's feeling anxious, and then he can't tolerate that feeling, so he does the video games, which pulls him out of that feeling. Like I feel like an interesting example that's kind of readily accessible, or kind of a place to start, is like, for instance, if you're, for me, when I'm feeling hungry, I tend to jump to like, oh my God, I'm hungry, I need to eat something right now. But like trying the mindfulness, the idea is like you create some space of like, oh, that's interesting. I feel hungry, and you can just like sit with that sensation without judgment, and trying to create that space. Because it might be it's something my body's telling me, but if I don't eat right now, I'm not going to starve. I'm not going to be injured. I can like sit and experience that sensation, and so practice with that can be really helpful.
I mean, it would be nice, like, as like a kind of like a multimodal approach, just like we have like obesity weight management clinic. Because I mean, I can listen to the videos and try to like do it in my 20-minute, appointment with my patient. But like, I'm not 100% trained in or whatever. But at least in the adult world, it looked like there was like, like 8-week intensive like mindfulness, like where you get like biofeedback, like you're smelling the rose, you got leads on your head. I mean, like it would be so great. I mean, I know I'm being very idealistic here, but if there's like a, UCSF or Stanford, even like psychiatric clinic, just like the obesity management clinic, where it's like a multimodal approach, and that somebody head up like the mindfulness part of it. I don't know, just a thought too. That would be cool.
Yeah. And there
This
are
is your next
some,
research project.
yeah, there's definitely, there's some of that going on in terms of certainly, in therapy, and when like kids are doing CBT and stuff, often kind of mindfulness and kind of relaxation skills are a part of that. There also are some, I don't know generally, but like in San Francisco, there are some like groups like Mighty Minds that does kind of groups for teens and kids about kind of mindfulness skills.
That would be
and
nice.
I think more and more in schools they're working on like having kind of social emotional curriculums that incorporate some mindfulness as well.
That is true.
But yeah, I agree. I think definitely could use more of it, and it's I think an important skill for all of us.
Exactly.
Apparently Sesame Street has a mindfulness app. It's called Stop, Breathe, and Think.
Nice.
And there's one called Smiling Mind from the Lego movie.
Smiling Mind I like a lot. That one's very good. And they have like kids specific kind of meditations too.
Yeah, so those seem like age appropriate. But by the time you get to teens, I think they could probably use Headspace and some of the other things that, yeah. The other thing I like to talk about with like younger kids is like bubbles and just like how bubbles are a way to promote deep breathing. Yeah. And so there are ways to adapt this, but you're right, there aren't these intensive kinds of programs for kids, which will be great. I mean, I don't know how they would respond to having stickers on their head, but they might respond to that cool, like kind of watch, right? That lets them do a little simple biofeedback about their heart rates and stuff. Yeah. Anyway, Ryan, I think you have your next project. As if you're looking for more, right? You probably have plenty. But anyway, we are at 1:15. It was wonderful to like keep on connecting with some of you, like beyond the top of the hour. And thanks for coming.